Hello everyone, my name is Dr. Gopesh Paul from Department of Biotechnology, St. Edmund's College. I'm assistant professor here. I'm teaching biotechnology subject in this college. Alright, so let me start with today's lecture. So the topic of today's lecture is hemophilia. So basically when we talk about this hemophilia, alright, we are going to know about the disease. What is this hemophilia disease? Okay, now basically in this lecture I'm going to talk about the definition of this hemophilia. What is the definition? Then I'm going to talk about the various types of this hemophilia. Then I'm going to talk about the diagnosis of this hemophilia, a little bit about the genetics of this hemophilia, and then coming to the laboratory diagnosis, then treatment, and then some prognosis. Alright, so basically when we talk about this hemophilia, the word hemophilia actually had come from two Greek words, hema or hyma, as we say. It is hyma meaning blood, okay, and philia meaning the affection or the lust for the blood. Okay, so that does not mean that any hemophilic patient has got some kind of a lust for the blood or affection for the blood, or they are some kind of a vampire. It's not like that. Hemophilic patient, if we want to define what is hemophilia and hemophilic patient, hemophilia is basically defined as some kind of a common genetic disorder, all right, common genetic disorder, which ultimately is basically related to the low or the decreased level of clotting factor 8 or 9. Okay, now what is this clotting factor? Clotting factor in the blood, we have got many different types of blood clotting factors, starting from clotting number 1, 2, 5, 10, 12, 11, 9, all those clotting factors. Alright, so in the blood, as we have got many different clotting factors, two of the clotting factors, that is clotting factor 8 and clotting factor 9, alright, they are reduced in hemophilic patient. The level of these clotting factors, they are not present or maybe present at a very low level, which plays a major role in clotting the blood. Okay, where in the blood, once we get some kind of a trauma, all right, or some kind of a bleeding happens in some patients, all right, with hemophilia. Now this bleeding, once it happens in these patients, now this bleeding may happen for many hours. It even may go for various number of days, all right, if the patient is having hemophilia. Now if a patient or if an individual does not have hemophilia, then what happens to the bleeding? The bleeding will be there for maybe few seconds or maybe few minutes, and because of these clotting factors which plays a major role in clotting the blood seeping is stopped, or the blood will get clot and there will be no more bleeding. Alright, now hemophilia, as I have already defined you, let me again define you. Hemophilia is defined as some kind of a genetic disorder, which is basically due to the deficiency or reduced activity of two of the blood clotting factor, that is factor number 8 or factor number 9. Okay, now talking about the types of hemophilia. Okay, let me just rub this. Now types of hemophilia. There are basically two different types of hemophilia. Hemophilia A, and hemophilia B. This is hemophilia B. Now basically when we talk about these two different type of hemophilia, what is hemophilia A? Now if there is a deficiency of only factor number 8, that is the blood clotting factor number 8, that is known as hemophilia A. That means, let me again repeat, deficiency of blood clotting factor 8 will lead to a disorder which is known as hemophilia, but the type is hemophilia A. Okay, and now this hemophilia A is also known as classic hemophilia, because this is the one which was discovered before. Okay, before hemophilia B was actually being discovered. Okay, now hemophilia B is basically due to the deficiency of blood clotting factor 9, and now this factor 9 is also known as the Christmas factor. It is not the festival Christmas, but then it is known as the Christmas factor. Okay, in the blood clotting factors. So this disease hemophilia B can also be referred to as, many times can also be referred to as Christmas disease. Okay, so these are the two different types of hemophilia, hemophilia A and hemophilia B. Okay, now let us talk a little bit about the genetics of this hemophilia. Okay, so far I think you people have understood what is hemophilia and what are the different types of hemophilia, that is hemophilia A and hemophilia B. Now, when we talk about the genetics of these hemophilia, because we know that it is a kind of a genetic disorder. What kind of genetic disorder I have not yet revealed. Okay, so let me reveal it to you that what kind of genetic disorder is hemophilia. Now, hemophilia is basically a rare X-linked recessive disorder. Okay, X-linked recessive disorder. Now, what is this X-linked recessive disorder? Now, we all know that females, they have got how many chromosomes? 2 X chromosomes, sex chromosomes. In case of male, we have got X and Y as a sex chromosome. Alright, now if we are talking about this hemophilia being the X-linked recessive disorder, that means this type of disorder should have a recessive type of a gene, right? I am talking about recessive type of a gene, not the dominant gene. So, if a female has to have this hemophilia, then in her X chromosome where the genes are present, okay, so genes are present in this X chromosome. Suppose just roughly I draw this chromosome, 2X chromosome as like this, okay. Now, there may be some kind of a gene, there are 2 genes, alright, which are responsible to give out the factor 8 or factor 9. They are responsible to make factor 8 or factor 9. Now, if these genes are present in its recessive form, okay, then they are not able to make factor 8 or factor 9. Okay, but if they are present in its dominant form, then they are able to synthesize factor 8 and factor 9, and thus blood clotting factors are synthesized properly. Blood clotting will happen or will occur in these individuals. Okay, now these factors, when we talk about factor 8 and factor 9, suppose this gene is responsible to form or to synthesize factor 8. Okay, so if I just write here as capital H, okay, so these two capital H corresponds to the dominant form of a gene, okay, whereby the dominant form of a gene, they are going to synthesize, they are going to prepare factor 8, okay. But if these are not present in its dominant form, rather they are present in its recessive form, that is small h and small h, that means the genes are not expressed properly. Genes are not going to express properly, genes are not going to make factor 8, alright, factor 8 or factor 9. So, if a female has got chromosome, sex chromosome, that is X and X, this X and this X, and in their X chromosome they have got recessive type of a gene, that means this female is going to have the hemophilia. This female is going to have hemophilia because in her both the X chromosomes she has got small h and small h. Alright, now talking about the male also has got 2 chromosomes, a pair of chromosome, one is X, one is Y. Okay, now if this males in case of hemophilia, because it is an X-linked recessive disorder, so like any other X-linked recessive disorder, males are very frequently getting affected with hemophilia, whereas females, they may act as a carrier of this disease, alright, whereby if a male, because it has got one X chromosome and this is X-linked recessive disorder, if the male has got in his X chromosome small h or the recessive gene, that means Y chromosome has got nothing to do, alright, with that gene. So, from this X chromosome, the recessive form of a gene is not going to produce that factor 8 or factor 9. So, obviously male, they are getting more affected due to hemophilia. Whereas in case of female, if one of the X chromosome has got recessive gene, another X chromosome has got the dominant form of a gene, that means one of the X chromosome is able to prepare factor 8 or factor 8 or factor 9, but another gene is not able to form. Okay, and because it is an X-linked recessive disorder, dominant factor is going to mask the effect of the recessive gene, and thus this female, though she has got in one of her X chromosome the recessive gene, but because she has got dominant gene which is able to prepare these two factors, she is not going to show the characteristic or show the symptoms of hemophilia. Though she is remaining as the carrier of this disease, she is able to transmit this disease to her progenies or to any of the generation through this small h, but then throughout her life she may remain as normal individual, but then she is going to have one of these recessive gene, so she is going to act as a carrier of this disease. All right. Now suppose these two pair, all right, that is the female, this is a female, all right, and this is a male. I hope my writings are clear to you all. Okay, this is XY, female and a male. Now this female, she is a carrier, so I'll just write here as X small h, because she is a carrier, she is not symptomatic, she is not showing any symptoms of hemophilia. She is going to have in another chromosome as dominant form of a gene, X small h, X capital H, and this male, all right, he is the one who is affected with hemophilia. So I'm going to write here as small h, X small h, Y. Okay, now normally these type of cases are very rare, where the female is also a carrier and the male is also an affected male. All right, this normally happens in those families where two individuals, male and female, they marry from the same family. All right, because they have the genetic disorders, they have heredited this problem, or they have been transmitted with these kind of a gene from their generation, above generation. All right, so here if these two marries, then they are going to have children. So one of the children, he is going to, or she is going, suppose this X, one of the chromosome from female will come, another chromosome from the male are going to come. All right, so if this female sends her X with small h, this male sends his X with small h. So because this is X and X, obviously it is going to be female. All right, and female, because both her X chromosome has got recessive form of a gene. So this is going to, this female or their daughter is going to have hemophilia. She is going to show all the symptoms of hemophilia, because her genes are not going to form the factor 8 or factor 9 kind of a blood factor. All right, and if these factors are not formed, she is obviously going to show the symptoms of hemophilia. Now another case, this X again will come from the female, X small h, and Y from the male will come. They are going to have son. All right, this is daughter and this is son. Now if you look into this one, now I think you people have understood. X small h, Y, obviously because it is XY, so it is a son, it is a male, and in his X chromosome he has got recessive form of a gene, so obviously he is going to show the hemophilia, symptoms of hemophilia. He is going to be hemophilic. All right, now in another case, this X with capital H will be transmitted, and this X with small h will be transmitted here, and because this is XX daughter, okay, this is X capital H, okay, this is X capital H, so she is also a daughter. But then if you look carefully here, one of her X chromosome has got capital H, another X chromosome has got small h, so she is going to be a carrier of hemophilia. She is not going to show the symptoms this time. All right, because she is just the carrier, because she has received one of her X capital H from the mother, but X small h obviously has to come from the father. So this X small h has come from the father, so she has become the carrier. Now the last son obviously has to get one X chromosome from the mother and obviously Y from the father. So this X with capital H will come from the mother and Y from the father for him to become a son. All right, male. Now this male, if you look carefully, is he going to show the symptoms? Is he going to be a hemophilic patient? No, because he has got X and Y to become a male, and his X chromosome has got capital H. That means his X chromosome has got the gene responsible to synthesize both the factors, that is factor 8 and factor 9. So he is not going to show the hemophilia, symptoms of hemophilia, or he is not going to be a hemophilic. Right? Okay. So this is about the genetics of hemophilia, why it is X-linked recessive disorder, and to happen, all right, for this hemophilia to occur, both the genes needs to be present in its recessive form. Then only they are going to be hemophilic. All right. Okay. So this is about little bit about the genetics of hemophilia. All right. So let me little bit talk about the pathogenesis. All right. So as we were talking about the hemophilia, a little bit about the genetics and all. So let us now talk about the pathogenesis of this hemophilia. All right. Now, as we all now know that the hemophilia disease is occurring due to some kind of a genes getting destructed in all those X chromosomes, right? Now, if these X chromosome has got genes which is getting destructed, all right, and which are not able to synthesize factor 8 or factor 9, this could be due to some kind of a mutation. What is mutation? Mutation is some kind of a activity which is happening to these genes, because when I say genes, genes, they are the linear sequence of DNA nucleotides like adenine, thymine, guanine, cytosine, adenine again, so ATGC. All right, so these sequence of DNAs, they are present in these genes, and because these sequence of DNA are getting deleted, all right, or maybe replaced, right, or maybe reversed, right. So because of all these activities which are happening to this gene sequence, hemophilia may happen. Okay, so now as I say, genes getting obstructed or genes getting damaged, all right, so that damage process of gene could be due to some kind of a deletion, all right, deletion, whereby one of the nucleotide in this gene sequence, one of the nucleotide is being deleted, and only one nucleotide is getting deleted, it is going to destruct the whole form of a gene, whereby factor 8, all right, factor 8 and factor 9 will not be synthesized properly, or maybe at a very low level they will be synthesized. All right, now in severe cases of hemophilia, okay, in severe cases of hemophilia, what happens? Many a times this whole sequence of the DNA which is forming the gene, they are getting reversed, all right, reversion, okay, whereby this is a kind of a chromosomal rearrangement, whereby this one, if it starts from here A to C, this is reversed where C is coming here and A is coming down. The whole sequence of the DNA has changed, all right. So with this whole sequence getting changed, there will be totally no production, no synthesis of this factor 8 or factor 9, and the patient is going to have a severe type of hemophilia, right. So there could be any different kinds of types of mutation which may occur to this gene, because of which the genes are not able to properly synthesize the factor, blood clotting factor 8 or factor 9. Now in some cases what happens is that in hemophilia, during mild hemophilia, right, during mild hemophilia, what happens is that there is mutation which is happening, which is called as the point mutation, which is known as the point mutation. Please remember this point mutation. Now this point mutation is basically only at one point of the side of this gene, all right, one of the nucleotide is getting deleted or being replaced by another nucleotide, right. Suppose the sequence is like A, T, T, G, C, C. Just arbitrarily, I'm just giving an example, A, T, T, G, C, C, right. Now this is the proper sequence of the gene which is going to give out the factor 8 to factor 9. Now if one of the nucleotide, that is T, at the third position is replaced by C, now the sequence is changed. Now they are not going to properly synthesize factor 8 or factor 9. They are going to synthesize factor 8 and factor 9, but then at a very low rate. Okay, so this type of mutation is going to have effect on the hemophilia, whereby the patient, they are going to have a mild hemophilia. So my hemophilia could be a mild hemophilia, moderate hemophilia, severe hemophilia, right. So severe hemophilia is basically due to the reversal of the gene. The gene is getting reversed, all right. Moderate hemophilia could be due to some kind of a deletion, or due to some kind of a production of some kind of a stop codons, all right, whereby the genes are getting some mutated to produce the stop codon, which is going to stop the synthesis of these factor 8 and factor 9, all right. And mild hemophilia could be due to the point mutation. I hope you people have understood. Point mutation, deletion, and then reverse, right, reverse mutation. Okay, so this is about the pathogenesis of the hemophilia. Now let us talk next about the hemostasis, because we have been talking about hemophilia, right. But exactly to the ground level, what is happening to our blood once our blood is coming out? Okay, so suppose we are having some kind of a trauma. I'm talking about the hemostasis. Okay, this is called as hemostasis, whereby we are talking about the blood is getting seeped out from the blood vessels. What happens to this blood? What is happening to this blood, where it is getting clotted and all, right? So first of all, if we are having some kind of a trauma could be anything, any cuts, right? Any cuts or any hurt that you have got in your skin or in your body, whereby bleeding is happening. Okay, so this trauma will do what? It is going to cause bleeding. It is going to cause bleeding through your tissues, through your blood vessels, right? Now bleeding, with this bleeding which is starting, okay, what happens? The blood vessels. So I think I better draw this blood vessels for you all. Okay, let me just draw the blood vessels roughly here. Okay, so suppose this is the blood capillaries, whereby in the blood capillaries we have these epithelial membrane which is lining the capillary membrane, capillary tissues. All right, epithelial membrane. Now this epithelial membrane is known as endothelial. This is known as endothelial, right? And this particular region above the endothelial or beneath the endothelial, this is known as the subendothelial collagen layer. Okay, that is, I'm just talking about the blood vessels now, right? Now subendothelial collagen, this is known as the endothelial. Now what happens? Suppose we are getting some kind of a trauma, some kind of a cut is happening, right? Now suppose this particular region of the blood vessels have got damaged, obstructed, right? Now with this damage occurring in this particular part, the endothelial is going to get destructed. Okay, the endothelial area is going to get destructed. So this is the part where the damage is happening to our blood vessels. From this part only the blood is going to come out, right? Now as this particular part is being destructed, there are some regions, all right, which are known as von Willebrand regions, right? Von Willebrand region. Now this von Willebrand regions will get exposed on the this one collagen layer, on the subendothelial collagen layer. Now to this von Willebrand region, right, there are platelets which are present in the blood. So let me just draw these platelets here. Platelets are present in this blood. Okay, now these platelets will do what? Platelets, they are going to adhere to these von Willebrand region. They are going to come towards this von Willebrand region, okay, and they are going to adhere, they are going to attach to this region, okay, and as they are attaching, this particular process is known as platelet adhesion. This process is known as platelet adhesion, adhering, attachment of platelets, right, to this region. As these platelets, they come and attach to this region, this platelets, they are going to expose GP1B type of protein, which is glycoprotein. On their membrane, they are going to expose GP1B type of glycoprotein molecules. Now with this exposure of GP1B type of glycoprotein molecule, more and more amount of platelets molecule, more and more amount of these platelet molecules will come and attach to each other, forming a proper kind of a cross-linking material, right? Now to cross-link these things, all right, to cross-link these things, there is a molecule which is known as fibrinogen. This is known as fibrinogen, right? This is actually fibrinogen, or say fibrin, right? Now fibrinogen will get activated, then only there will be a proper type of a cross-linking. Now this fibrinogen will link all these platelet molecules together and will make these platelet molecules to gather here more and more, which is known as platelet aggregation. All right, so next one is after platelet adhesion, which is known as platelet aggregation. Okay, now this platelet aggregation, with this platelet aggregation which is happening, more and more amount of glycoprotein, that is glycoprotein GP2B and 3A, GP2B and 3A, all right, they will be exposed on the sides of, on the membrane of these platelets, and more amount of this platelet will adhere together, will aggregate together on this particular area. Now, as these platelets they adhere, they aggregate in this particular area, they are going to form a platelet plug. A platelet plug. Now, this platelet plug which is formed here, it is very unstable, right? Only once this platelet plug becomes stable, then only we say that the bleeding is stopped. This, because of this platelet plug only, the bleeding gets stopped. Clotting happens. There is no more bleeding. In normal individuals, these things happen, right? There is a bleeding. Now, platelet adhesion to this 1 Willebrand site. Okay. Now, platelet aggregation will happen, and they are going to form platelet plug. Now, who is going to make this unstable platelet plug stable? It is the clotting factor. It is the clotting factor which is also present in our blood. Now, all these clotting factor will come into picture, which is known as, and they are going to go through the processes of clotting, right, which is known as coagulation, which is known as coagulation cascade. Coagulation cascade. Now, this coagulation cascade, to understand, you have to understand about all the different kind of blood clotting factors. Which one is the most the first blood clotting factor which acts, right, on the next? So there is a kind of a cycle, kind of a reaction whereby clotting factor 12 is going to become clotting factor 12A, which is going to activate 11 to 11A, now 11 to 9 to 9A. So like this, coagulation cascade is being formed. All right, all the clotting factors, they are going to play their role in this coagulation cascade, and once this clotting factor they have played their role, enough role, now they are going to form fibrin. Now they are going to form the fibrin in the presence of thrombin, in the presence of, let me just write it properly, thrombin. This is thrombin. Okay. Now this fibrin, once it is formed, this fibrin is going to now make this unstable plug, platelet plug, to stable platelet plug. This stable platelet plug will be formed only when the fibrinogen, as I have discussed already, these red mark which is linking these platelets, all right, it remains as fibrinogen, all right, which is the inactive part of the fibrin molecule. This is going to get converted into fibrin, and thus the cross linking of these platelets will happen very strongly, making this particular region to stop the flow of blood anymore. Okay. Now the flow of blood outside these tissues will stop because of the formation of this stable platelet plug. Okay. So this is about the hemostasis of the blood which is happening in our body, right? Now in normal patient this is happening, normal individual, but in a hemophilic patient what is happening? This coagulation cascade is not happening properly, and with this coagulation cascade not happening properly, fibrin is not able to form, all right, because this coagulation cascade is not going to convert this fibrinogen into fibrin, and thus stable form of platelet plug is not formed, and thus continuous bleeding tends to happen. Continuous bleeding tends to happen in these individuals for several days. All right. Suppose you go for some kind of a tooth extraction, right? A person is hemophilic. He has gone for a tooth extraction. After the tooth has been extracted, the blood keeps on flowing for several hours. All right. So these things are actually more prone to these hemophilic patients, right? It is not with us. If I am not hemophilic, my tooth is being extracted 100 number of times, blood clotting will happen, because all these cycle of things are happening in my body, in my blood, because my blood is okay with platelet adhesion is happening, platelet aggregation is happening, coagulation cascade, because all my blood factors, they are working properly, they are going to play the role in this coagulation cascade, and they are going to form the fibrin, and finally the stable form of a platelet plug is formed. I am well and good, right? Okay. So now this is about the hemostasis. Now let us so I will not go into detail of this coagulation cascade. I'll just share the slide, all right, the coagulation cascade. You all can just go through that coagulation cascade, what is happening, what are the different types of blood clotting factors which are playing their role in the coagulation cascade. You can all can see that. All right. Now coming to the next subtopic of this hemophilia, So now let us talk about the clinical features or the clinical findings of this hemophilia. All right, now by the term clinical findings or clinical features, we understand that because this hemophilia is happening, okay, because this hemophilia is happening, what is happening to our body? What are the clinical findings? Okay, so if a person is having this hemophilia, then this person or the patients, they are going to have different types of a problem, different kind of a complications. Like, so these complications may include like your joint pain. All right, joint pain meaning there will be a bleeding in the joints. All right, now with this bleeding which is happening in the joints, and which is the term, there is a term for this disease which is known as hemarthrosis. Okay, so in case of severe hemophilia, what happens, there is a internal bleeding in the joints, and due to this bleeding problem which is happening, the muscles are getting cramped, the muscles are getting damaged, and finally the limbs are getting damaged. With our hands or our legs, okay, they are getting damaged. So these are the clinical findings of this hemophilia. Now, to talk more about this hemophilia, the joints that I'm talking about, some of the common joints could be our knee joint, then ankle joint, then shoulder joint, then our wrist, okay, then hip joint. So these are the area which are getting more affected in a hemophilic patient, a person with a severe hemophilia. All right, now in some cases, some very rare cases, what happens is that, in a matter of fact, what happens is that there's a severe intracranial hemorrhage. All right, intracranial hemorrhage. So if this happens in a hemophilic patient, intracranial hemorrhage, then what happens, it will take away the life of that patient. Okay, that is very dangerous. So a proper kind of a treatment needs to be done, or a proper kind of a diagnosis needs to be done. So when we talk about this diagnosis, I think I've talked about the clinical features, what are the different type of complications, what are the different types of problems a hemophilic patient may face. So laboratory diagnosis, when we talk about laboratory diagnosis, a proper diagnosis, okay. Now laboratory diagnosis is going to include diagnosis, okay. Okay, so a proper kind of a test needs to be done, because what happens is that during hemophilia, the blood coagulation time is normally it's prolonged. Blood coagulation time meaning the coagulation, the clotting of the blood is prolonged. It does not take place at once or very quickly. It takes a lot of time, right? So that particular blood coagulation time is prolonged, and because of this, there are two different types of we can say it's a kind of a molecule, all right, which the level of this may increase. And these two molecules, normally when we go for laboratory test, they normally go for PTT, to check for PTT level or PT level. Now what is this PTT and PTT, PT or PTT level, right? Now this PT is the prothrombin time. Now what is this prothrombin time? Again, I have to talk about the coagulation cascade. Now very roughly, very quickly, I will just draw. This is factor 7, okay. Factor 7 starts with the intrinsic pathway of coagulation pathway. Intrinsic, this is intrinsic pathway, okay, pathway. Now this intrinsic pathway is going, if this intrinsic pathway is disturbed, or if there is a problem in the intrinsic pathway of the coagulation cascade, then the prothrombin time is elevated, is increased, right? So if you go for laboratory diagnosis and we find that the level of PT has elevated, has increased, that means there is a problem with the intrinsic pathway of the coagulation cascade, right? Now other than this intrinsic pathway, there is also extrinsic pathway, extrinsic pathway. Now this pathway of coagulation cascade, all right, it is going to tell us about the level of PTT, that means partial thromboplastin time, If there is a problem with the extrinsic pathway of coagulation cascade, then the level of this one, partial thromboplastin time, is going to increase. So laboratory diagnosis, if you find that this has increased, that means the extrinsic pathway of the coagulation cascade is, there is a problem with this one, okay. So this extrinsic pathway starts with factor 12, okay, factor 12, then factor 11, then we have factor 9, okay, then we have factor 8, all right, then we have this factor 10 which is present here, and then goes on with 5, then 2, then 1. Okay, so both the extrinsic pathway and intrinsic pathway has to activate factor 10 here. All right, factor 10 needs to be activated through both the extrinsic and intrinsic pathway of coagulation cascade. So where do we find factor 8 and factor 9? We find factor 8 and factor 9 present in the extrinsic pathway. Have you all got it? Factor 8 and factor 9 is present where? In the extrinsic pathway. So these two factors, because of the deficiency of these two factors, a person is going to get hemophilia. Could be either hemophilia type A or hemophilia type B. If it is deficiency of factor 8, hemophilia A, deficiency of factor 9, hemophilia B. All right. So normally in hemophilia, extrinsic pathway of the coagulation cascade is being affected. All right. Whereas in these hemophilia patients, when they go for this kind of a laboratory diagnosis, it is always a high level of PTT is being shown in their report. Okay, which means that factor 9, there is a problem with the factor 9 and factor 8, which is playing a role in the extrinsic pathway of the coagulation cascade, all right, or the coagulation pathway. So once the factor 10 gets activated, this factor 10 is going to activate the prothrombin, as I have discussed, to thrombin, okay, to thrombin, and this thrombin is going to activate fibrinogen, okay, fibrinogen to fibrin. And once this fibrin is formed, a stable form of that platelet plug is being formed. That stable form of platelet plug is formed, and clotting happens, or the coagulation of the blood happens. Okay, so this is about the laboratory diagnosis. So laboratory diagnosis may include all these different types of a test, as well as there are also various assays. There are various assays whereby these assays may include factor 8 assay, factor 8 type of assay, and factor 9 type of assay. These are enzymatic assays. Whereby these two factors are being isolated. All right, they are extracted out, and there are various types of protocols which are used to find out the level of factor 8 and factor 9, which is known togetherly or collectively as factor 8, factor 9 enzymatic assays. All right, to know the level of these two. Okay, so this is about the laboratory diagnosis. What are the diagnoses which is happening in the laboratory, okay, or in the pathological lab in the hospitals and all. So since we have talked about the laboratory diagnosis of this hemophilia, and once it is diagnosed, okay, a individual is being diagnosed with the hemophilia, then what are the treatments that is being given to these patients? All right, so normally if doctor finds that regarding the treatment, if a doctor finds that a patient is having a kind of a mild hemophilia, all right, if it is a mild hemophilia, then normally doctor prescribe that patient with a chemical or a drug which is known as desmopressin acetate. Okay, this could be administered intravenously to the patient, and this desmopressin acetate, what does it do? It goes and starts or increases the release of factor 8 from the storage site, because factor 8 is not being released properly in these individuals with mild hemophilia. All right, so what happens? This drug, once it is administered into these patients, they are going to increase the release of this factor 8 from their storage site. So as the level of this factor 8 increases, then the blood clotting may happen in these individuals with mild hemophilia. But in case of severe hemophilia, what happens? In case of severe hemophilia, normally factor 8 is not being produced, is not being synthesized at all. Then what do? We cannot just administer that patient with the desmopressin, because there is no storage site at all for this factor 8 to get released in those individuals. Then what do? We prepare manually in the laboratory, we prepare the recombinant type of factor 8. All right, we prepare this factor 8 in the lab. Now this recombinant factor 8 is being infused, taking proper care, all right, in the hospital, and it is being infused into these patients with severe hemophilia, where this factor 8, recombinant factor 8, is just going to do the purpose for us. It is going to act similarly like factor 8 in the body of those severe hemophilic patients, and thus bring about the clotting of the blood or the coagulation of the blood in those individuals, so that more bleeding should not occur on in those individuals or in these patients, right? Now, many times what happens, it is seen that in the hospital, even after infusion of this recombinant factor 8, all right, it does not work. The patient body does not actually stop bleeding. The bleeding keeps happening continuously. Blood is being coming out. All right. So it is due to the immune rejection. The reason could be due to the immune rejection which is being given from our body, immune cells. All right. Because our immune cells, we are well equipped with our immune system. So our immune cells is not going to accept anything which is coming from the foreign, which is coming from the outside environment, all right, outside our body. So our immune system, they are not going to recognize this recombinant factor 8 as our own protein molecule or our own molecule, and they are going to reject this factor 8, recombinant type of factor 8, and thus in these patients it becomes very difficult, it becomes very tough, all right, to treat these severe hemophilic patients with even the recombinant factor 8, all right. So in that case, some other methods is being used, some other kind of a protocol is being used by the doctors in the laboratory or in the hospitals, all right. So this is about the treatment of hemophilia. Now, since we have talked about hemophilia, types of hemophilia, then the pathogenesis, then the hemostasis, then and then we talked about the genetics of this hemophilia, clinical features or clinical findings, treatment. Now let us little bit talk about the prognosis, right? Because when we talk about the prognosis, we normally look for a healthy treatment prognosis, right? So if the patient with hemophilia, if they are treated or they are diagnosed well in time, properly being diagnosed, properly being treated, then it is good for the hemophilic patient, all right. It is always good for the hemophilic patient, because once the treatment is done properly, they are able to synthesize, they are able to live healthy life, they are able to live a good kind of a life, all right, because in their body they do not have to wait for this factor 8 or factor 9 to work for them. Instead, that treatment could be either by desmopressin acetate or could be either by recombinant factor 8. These things, they are doing the work for them to live a healthy type of a life, all right. So prognosis is always good for this homeostatic or hemophilic patient, all right. Now, since we have finished everything, since we have come to an end of this one, let me just put one question in front of you, all right. You all think and then you find out the answers by yourself. As we talked about this hemophilia, it is a rare sex-linked recessive disorder, okay. So that means it is hereditary, it is being heredited, it has been transmitted from parental generation to the offspring and generation after generation, right? Do you find a individual who do not have a history, family history of any kind of this hemophilia in the family, right? Can that individual have hemophilia, or that individual or any individual with no family history of hemophilia is never going to have hemophilia in their life? Think about it. If you think, you are going to find the answer, you are going to explore more on this topic, and if you want me to give the answer, I'm going to come again in the next session. I'll give you the answer. All right. So with this, I finish. Thank you. Namaste, and we'll meet again. Thank you.